Now, what is the other investigation that can be done for a patient who is coming with acoustic neuroma diagnosis? You can do a WEMP. Why will you have to do a WEMP? With WEMP, you can know whether the inferior vestibular nerve is affected or the superior vestibular nerve is affected. How? Because it is the inferior vestibular nerve pathway that is resulting in CWEMP. Okay, in CWEMP, what is being measured? It is the relaxation of ipsilateral sternocleidomastoid muscle with exposure to loud sounds through the saccule and the inferior vestibular nerve. Okay, this pathway is getting assessed in CWEMP, whereas in OWEMP, it is the opposite extraocular muscles that are getting relaxed with exposure to loud sound, and here it is through the utricle and the superior vestibular nerve. Okay, so that is the importance of assessing the vestibular evoked myogenic potential for an acoustic neuroma. Now, what is the staging of acoustic neuroma? How will you stage acoustic neuroma? In stage 1, which is the otological stage, the tumor is confined to the internal auditory meatus. The internal auditory meatus is only 1 centimeter, right? So, what is happening here? Only the structures within the internal auditory meatus is compressed. So, the patient will be having deafness, tinnitus. Okay, there won't be vertigo because of the compensation, but a mild unsteadiness may be present. Okay, that is what is called as a stage of otological stage, and here the tumor is in the internal auditory meatus. Now, when it comes out from the internal auditory meatus to the CP angle, then it can go and compress the trigeminal nerve that I already told you, right, and that can result in facial numbness and loss of corneal reflex, and that is what is called as the stage of trigeminal nerve involvement. Okay, that is the second stage, and this can result in loss of corneal reflex. Okay, in the third stage, what happens? It goes further and goes on to compress the cerebellum. That is what is called as the stage of cerebellar involvement. Okay, stage of cerebellar involvement. And what is happening in stage of cerebellar involvement? There will be ataxia. The patient will be having cerebellar ataxia, and when you are doing the test, what happens? There will be a rebound phenomenon present. Okay, and when you do a finger nose test, there will be an alternation seen, and dysdiadochokinesia also will be present. Okay, so that is what is known as the stage of cerebellar compression. Now, what is the final stage? The patient will be having headache with vomiting plus papillar edema, and this is the stage of increased ICT. Okay, the final stage is the stage of increased ICT. Okay, or intracranial tension. So these are the 4 stages of the CP angle tumor that you have to know about. Okay, now how will you treat a case of a CP angle tumor or acoustic neuroma? Will you straight away go for surgery? No. In elderly, actually you can wait and watch. Okay, why? Because it is a slow growing tumor, right? It is a very slow growing tumor, and if it is small, you can wait and watch. Okay, if it is only millimeters in size, then you can take a close follow-up of the patient and then do repeated audiogram every 3 to 6 months. Okay, and like that you can keep a watch on the patient, and if necessary you can do an MRI to look for the increase in size of the tumor. Okay, so that is the first step that you can do in patients who are having a small tumor and who are elderly. When the tumor is larger but it is less than 3 centimeter in size, when it is 3 centimeter in size, it would have involved the CP angle, right? The internal auditory meatus is only 1 centimeter in size. Beyond that, when it is going to 2 to 2.5 centimeter to 3 centimeter, what happens? the tumor will extend to the CP angle and it finally gives the ice cream appearance in the MRI. Okay, so if it is less than 3 cm in size, even though it has involved the CP angle, you can do something. What is that? You can go for a stereotactic radiotherapy, which is also known as gamma knife therapy. This will help in the arrest of growth of tumor. Okay, it will cause arrest of growth of tumor. So that is the importance of giving a stereotactic radiotherapy or a gamma knife therapy. Okay, so you can go for a gamma knife therapy. Now, if the patient needs a surgery, as I already told you, there are certain indications for surgery, like when there are cystic areas present, when it is large in young patients, especially in a case of bilateral acoustic neuroma, when you are having a NF2. NF2 can cause bilateral acoustic neuroma, whereas NF1 can cause unilateral vestibular schwannoma. Okay, that is one thing you have to know. NF1 causes unilateral vestibular schwannoma, whereas NF2 causes bilateral vestibular schwannoma. In that case, you will have to go for surgery. Okay, now what are the various surgical options available for a patient with vestibular schwannoma? You can go for either the middle cranial fossa approach. Okay, middle cranial fossa approach, when it is a small tumor, it will help in hearing preservation. Okay, hearing preservation is there when you are going for a middle cranial fossa approach. Okay, when you are going for this approach, the middle cranial fossa can be identified easily by identifying the greater petrosal nerve, which is coming from the genu. Okay, that is a landmark for identifying the middle cranial fossa. Another landmark is the arcuate eminence. And once you reach the internal auditory canal, how will you differentiate between vestibular, superior vestibular nerve and the facial nerve? By looking at the Bill's bar. It is named after the father of neurootology, who is that? William House. Okay, now if hearing is not preserved, you can go for translabyrinthine craniotomy. Okay, translabyrinthine craniotomy can be done. Here the hearing also will be lost. Okay, it is done for larger tumors. Okay, another approach is a retroauricular approach, that is suboccipital craniotomy can be done for removal of the vestibular schwannoma. Okay, so these are the various surgical options available for a patient who presents with a vestibular schwannoma. Now coming to one of the most commonly asked questions from this topic. What is that? What is the earliest ocular finding in acoustic neuroma? Is it diplopia, ptosis, inability to close eyes, loss of corneal sensation, or is it papilledema? What do you think? What did I tell you? I told you that when a patient is having an acoustic neuroma, it is a loss of sensation in the posterior superior part of the external auditory meatus, which is the Hitzelsberger sign. That is the earliest sign that you get. Okay, but it is very difficult to elicit. But when you are asked which is the earliest ocular sign, it is the loss of corneal sensation, and that is what is resulting in the loss of corneal reflex, and that is what is called as the teal sign. Okay, teal sign, and this happens when it goes into the second stage, that is when from the internal auditory meatus it goes into the CP angle to involve the fifth cranial nerve, the trigeminal ganglion. When it is involved, that results in teal sign. Okay, inability to close eyes is when the motor part of facial nerve is involved. Okay, motor part of facial nerve is relatively resistant compared to the sensory part. Even though the sensory part is involved very early, that results in the Hitzelsberger sign. Inability to close eyes occurs later only. Okay, so that is occurring late. Ptosis is also not seen because ptosis occurs when there is involvement of third cranial nerve. That is not usually involved. Diplopia is involved when the sixth cranial nerve is involved, but before that the loss of corneal sensation will be present. Papilledema occurs only later, the last sign of increased ICT. The last stage of increased ICT only papilledema occurs. coming to the next question, what is the earliest sign in acoustic neuroma? Yeah, I told you it is the Hitzelberger sign which is the earliest sign in acoustic neuroma, but there is no such option. Unilateral deafness is the earliest symptom in acoustic neuroma, but not a sign. Okay, when you are asked earliest sign, it is again reduced corneal reflex. Okay, now when a patient who is having a bilateral acoustic neuroma and had to undergo the excision of acoustic neuroma presents to you, how will you rehabilitate the patient? Okay, what is the method of rehabilitation for that patient? Can you put a cochlear implant? No, because we are excising the vestibular nerve, right? So you can't put a cochlear implant. So what is the other option? You can directly stimulate the cochlear nucleus, and for that you have the auditory brainstem implant. Okay, auditory brainstem implant looks similar to the cochlear implant. It has got an external sound processor, a microphone. Okay, and there here you have the receiver stimulator similar to a cochlear implant, and from there, but instead of going into the cochlea through the round window niche to the positive anatomy approach in case of cochlear implant, here it is going into the lateral recess of the fourth ventricle where you have the cochlear nucleus. Okay, lateral recess of the fourth ventricle has got the cochlear nucleus and it directly stimulates the cochlear nucleus. There are two types of cochlear nucleus, the dorsal and the ventral cochlear nucleus, and they are getting stimulated directly by the auditory brainstem implant. Okay, and they are located in the lateral recess of the fourth ventricle. Okay, so auditory brainstem implant is used for rehabilitation of a child or a young person who is having bilateral acoustic neuroma excision. Okay, in that case you can use a cochlear implant, so you are going for a auditory brainstem implant, and this was also invented by William House, and this was invented with association with William Hitzelberger. So the auditory brainstem implant was invented by William House and William Hitzelberger, after whom the Hitzelberger sign was named. Okay, so that's about the things that you have to learn in case of acoustic neuroma. What are the things that you have learned today? We have learned that acoustic neuroma is a misnomer and it has to be named as vestibular schwannoma, as it arises from the Schwann cells of the vestibular nerve, most commonly inferior vestibular nerve, and yes, it is a benign but locally invasive tumor and it is unencapsulated, and this tumor presents with a unilateral deafness plus tinnitus. These are the earliest features, but the earliest sign is the loss of corneal reflex. This is the earliest sign that can be elicited. Okay, the earliest sign is Hitzelberger sign, and this happens when it goes into the CP angle to involve the trigeminal area. Okay, so that is the sign in case of a patient who is having vestibular schwannoma going into the CP angle. And what else can occur? The patient will have cerebellar ataxia in the later stage when it goes into the cerebellum and compresses it. Okay, and that is what is called as a stage of cerebellar compression, and finally it can cause increased intracranial tension. Okay, increased intracranial tension also can occur in vestibular schwannoma. Now what are the treatment options? Treatment options, you can go for stereotactic RT or gamma knife RT when the tumor is less than 3 cm. Okay, if more than 3 cm you have to go for surgery, and in small tumors in elderly you can actually go for a wait and watch management. Okay, so these are the things that you have to learn in vestibular schwannoma. A small topic, easy topic. Please go and read today itself because questions are asked from this area also. Okay, thank you.